A 20-year-old woman, gravida 1, para 0, at 36 weeks of gestation, delivers a stillborn infant. She has no prenatal care. She has no prenatal care, and the prenatal course was complicated by maternal cocaine and alcohol use. She also was seen in the emergency department at 20 weeks of gestation after being assaulted by her boyfriend. Examination at the time showed a scalp and the forearm laceration and bruising of the abdomen and the face. She took phenytoin during the pregnancy for a seizure disorder. She had no seizures during the pregnancy. An autopsy of the fetus shows multiple fracture of the thin ribs and multiple fracture of rather broad and ribbon-shaped tubular bone. Examination of the fetus shows blue sclera, soft calvaria, and a small chest, bent, short extremities. Which of the following is the most likely cause of this condition?
Ready? Ready?
Yes.
There is abnormality on type 1 collagen. The infant likely died from complication of osteogenesis imperfecta, which result from mutations or post-translational defects in collagen type 1. Given the presence of collagen type 1 in bone, skin, and connective tissue, pathology results from connective tissue defects ranging in severity from postpubertal fractures to fatal fractures in utero. Postpubertal fractures, okay. The presentation of this fetus likely reflects fragile bones along with decreased calvarial ossification and thin sclera, leading to visualization of choroidal veins. Patients may also present with uh, short stature, scoliosis, basilar skull deformities leading to nerve compression, hearing loss, likely related to abnormal bone formation in the ossicles and cochlea, opalescent and fragile teeth, and easy bruising caused by collagen type 1 defects in blood vessel walls. Treatment is primarily supported involving possible bisphosphonate along with monitoring for complications, physical therapy, and genetic counseling. Okay, next.
A previously healthy 1-year-old boy is brought to the physician because of 2-month history of increasing weakness and difficulty feeding. He is alert. Examination shows tongue fasciculation and profound hypotonia. Deep tendon reflex are absent. Which of the following is the most likely diagnosis?
Still fasciculations, invasive infantile muscular atrophy, and spermatitis, difficulty feeding. Hmm. Ready?
Yes.
Hmm. So is progressive infantile spinal muscular atrophy. Oh. This patient most likely has progressive infantile spinal muscular atrophy (SMA). SMA commonly involves autosomal recessive mutation of the SMA protein, resulting in defective mRNA synthesis in motor neurons. Okay. The infantile form of SMA typically affects normally developing infants who are several months old. And in spinal muscular atrophy, the bilateral lower brainstem motor nuclei and anterior horns degenerate, leading to progressive symmetric muscular weakness and the lower motor neuron pattern of dysfunction, decreased tone, hyporeflexia, fasciculation, early onset atrophy. The lower extremities are typically more affected than the upper extremity. Dysfunction progress over the course of months. In severe cases, progressive respiratory insufficiency may develop. The diagnosis can be confirmed with genetic testing. Treatment is supporting and includes promoting nutrition, motor, and respiratory function. Botulism is an acute disease in the neuromuscular junction caused by exposure to Clostridium botulinum, example in raw honey. Over the course of hours to days, patients develop symmetric hypotonia and aporeflexia that begins with cranial nerves and descends to the lower extremity in a presentation that mimic SMA. However, this patient weakness develop over the course of months rather than hours to days. It is not as myasthenia gravis, autoimmune disorder of neuromuscular transmission, that may result in focal or generalized muscle weakness and fatigability. Myasthenia gravis demonstrates a bimodal age of onset in both young adults, teens to 20s, and older adults. Myasthenia gravis in an infant would be atypical. Okay, it's not transferred myelitis, acquired condition in which inflammation from an infection or autoimmune disease affects one section of the spinal cord bilaterally, leading to acute motor sensory and autonomic dysfunction. This patient is instead experiencing serious onset of motor dysfunction only. Okay, motor dysfunction only. Okay, next.
Yes. An asymptomatic 10-year-old boy is brought to the physician for a well childbearing examination. He has no history of serious illness, takes no medication. His parents both have essential hypertension and hyperlipidemia. He has an active lifestyle and plays several sports. He consumes a wide variety of foods, including meat, fruit, and vegetables, and drinks 2 to 3 glasses each of whole milk and fruit juice daily. He is currently at 75th percentile for height and above 97th percentile for weight and BMI. Vital signs are within normal limit. The remainder of the examination shows no abnormality. Which of the following is the most likely cause of this patient's current weight?
Is it fat or is it carbs? Carbs, maybe. Whole milk. Whole milk may be fat.
2 to 3 glasses of milk, isn't it bad?
I
Like,
think so. It's fat. But milk, is it fat or is it carbs?
what is your diagnosis?
I don't know. He's fat.
I don't know. Truly, I don't know.
I mean, we know
I
he's
am
fat.
thinking about fat because 2 to 3 glasses of
Yeah.
whole milk is not good for health.
And also, the fruit juice is not good, also. The fruit juice, I mean, the fruit is good, but the fruit juice daily is not good. So I'm
Oh,
guessing it's fat.
okay, let's jump into fat.
Oh my goodness. Total calories. In children, overweight is defined as BMI at or above 85% and below 95 for age and gender, while obesity is BMI above at or above 95. So 85 overweight, 95 obese. This obese child consumes balanced diet, but one that most likely contains excessive total calories. Common cause of childhood obesity include consuming a diet rich in unhealthy caloric-rich food, and lack of sufficient exercise. Children from socioeconomically disadvantaged communities may face significant difficulties in obtaining healthy food and sufficient opportunities for exercise. Children with obesity are more likely to develop comorbidities such as hypertension and diabetes. Excessive fat intake and excessive carb intakes are both correct but insufficient to explain this child's obesity. The child consumes a balanced diet as well as several glasses of both milk and fruit juice daily, and is likely consuming an excess of both carbs and fat as well as protein. Okay, so we know here he's drinking a lot of milk. We were right. He's drinking a lot of fruit juice, which is not good. But they're assuming that that means he's also eating a lot of meat and
Carbs. Okay.
yeah, all of
So
that.
he is taking everything.
Yeah. I mean, if they had said that he's eating meat every day, I feel like we would have got it. But they said variety of food, and I know meat is good. If it's not too much, it's good. So okay, next.
A 10-month-old girl is brought to the physician because of 5-day history of rash over the cheeks and the diaper she constantly rubs. Her mother says that the past 24 hours she has been unwilling to stand. She is febrile and otherwise healthy. Her mother and 6-year-old brother have asthma. Examinations show erythematous lichenified papule and plaques and excoriation of the diaper area. She has red lichenified plaques on the cheek and the chin. Which of the following is most likely diagnosis?
Like any fat. Ready?
Yes.
Mm. So it is atopic dermatitis. Atopic dermatitis or eczema is a chronic pruritic inflammatory skin disease common in children that is suggested by pruritus and recurrent eczematous rashes. The rash is initially characterized by red papules and vesicles with exudates and crusting, and with chronic scratchy becomes dry, scaly, and excoriated in a process called lichenification. Flexural dermatitis, example in the antecubital fossa, is a common pattern in children and adults with atopic dermatitis, but babies demonstrate a unique pattern which primarily involves the bilateral cheeks and diaper area, as this area are both frequently moist and subject to irritation. Treatment of atopic dermatitis begins with gentle skin care, minimizing long bath in warm water, which causes drying of the skin, avoiding products with fragrance, and use of blend moisturizers such as petroleum jelly daily. In the case of an infant, keeping the cheeks dry and frequent diaper changes are also important. Flares of eczema are treated with mild to moderate potency topical steroids such as triamcinolone. In children, a moderate potency topical steroid should not be used consistently for over 2 to 3 weeks because potential of systemic abortion, ah, absorption particularly in diaper area. Snow candidiasis can affect mucous membranes of skin. Other candidiasis demonstrate thick white plaques on the tongue and buccal mucosa, which can be scratched off. Cutaneous candidiasis demonstrate red macerated thin plaques with satellite papules. Candidiasis is a common cause of diaper rash. In this case, given the additional findings of face atopic dermatitis is more likely. Okay, next.
An otherwise healthy 6-year-old boy is brought to the physician because of growth of pubic hair the past 2 years. He is 157 centimeter, 5 feet 2 inch tall, weight is 50 kg. He appears muscular. Pubic hair development, Tanner stage 5. Examination shows a mature penis. Testicular volume is normal for age. Which of the following is likely site of excessive hormonal production?
Mm. In between
Six
6 year old
six
in his
year
father,
old boy Tanner stage 5 pubic hair, so very high.
very high. So is it testes or adrenal cortex? Because both can produce androgens. And then it's adrenal cortex because they're saying testicular volume is normal. So I'm thinking it must be adrenal cortex. Okay, ready?
Yes.
So it's adrenal cortex. Precocious puberty is defined as the onset of pubertal development and secondary sexual characteristic prior to 8 years old in girls and 9 years old in boys. Precocious puberty can be central, which is caused by activation of the HPO axis, hypothalamic pituitary gonadal axis. This early activation can be idiopathic or caused by central CNS abnormalities such as brain tumor. Precocious puberty can also be peripheral, which is caused by release of excess sex hormones from gonads or adrenal glands, or potentially the ectopic production of HCG from a germ cell tumor. Initial evaluation involves the measurement of FSH, LH, and estradiol and testosterone, which allows the provider to differentiate between central and peripheral causes of precocious puberty. Central puberty is further evaluated with brain imaging, whereas precocious puberty is further evaluated with ultrasound of the testes, ovaries, and adrenal gland. Treatment is dependent on the underlying cause. Testicular size is based on the production of
What will happen the FSH, LH, and estradiol in case of central and peripheral precocious puberty?
central. I'm guessing central FSH, LH will be high, testosterone will be high, and then peripheral testosterone will be high, FSH, LH will be low.
Okay.
As testicular size is based on the production of FSH, this patient more likely has peripheral cause of precocious puberty with hyperandrogenism leading to inhibition or release of GnRH, FSH, and LH. Okay, so because the testes are normal, then
Peripheral.
is peripheral. Adrenal cause of precocious puberty include congenital adrenal hyperplasia, androgen secreting tumor. Treatment for precocious puberty is dependent on the underlying pathology. And it's not, which one was E? What is E? What is E? Right here. Excess hormone production from the testes can present with peripheral precocious puberty seen in this patient. However, the most common cause of testicular pathology leading to precocious puberty in young boys is Leydig cell tumor, which can be expected to present with asymmetric enlargement of the testes, not seen in the yeah, makes sense. Okay, next.
So we evaluate the central versus peripheral, like
Mm-hmm.
how we can evaluate the precocious puberty. Early, if there is early secondary sexual development, like in these cases, early secondary sexual development, if the age is advanced bone age, then we will do high basal LH. So if basal LH is high, like high basal LH, it is central precocious puberty. And if we do low basal LH, if the LH is low, advanced bone age, but basal LH is low, then we will do GnRH stimulation test. If it, if the LH is still high, then it is central precocious puberty, and if the LH is low, then it is peripheral precocious puberty. Okay,
Mm-hmm.
so we will see the LH level. LH. Okay. A 3 week, sorry, a three next.
Mm-hmm.
A, a 3 week old boy is brought to the for physician 4 hours after the onset of vomiting a watery green material. His mother says that he has been drawing up he has been drawing up his legs as if in pain while vomiting. He appears uncomfortable and he is afebrile. The abdomen is tender but not distended. Abdomen legs ratio, dilated loops of small bowel, and air fluid level. Which of the following is the most likely diagnosis? Mm,
Ready?
yes.
It's volvulus. Um, Volvulus occurs when a portion of the GI tract twists, leading to bowel obstruction. Midgut volvulus usually occurs in children who have intestinal malrotation, a congenital anomaly in which the midgut incompletely rotates during development, and typically presents within the first year of life. The most common initial symptom in infants is vomiting, which become bilious as a result of the blockage of the small bowel and the retrograde flow of bile. In older children, abdominal pain is the most common presenting symptom. The diagnosis can be confirmed with imaging. Then X-ray are required first to screen for perforation. Once perforation has been excluded, an upper GI contrast series is obtained. Imaging study may show evidence of malrotation with a small bowel obstruction, including air fluid levels and dilated loops of bowel. If not recognized quickly, volvulus can lead to vascular compromise with subsequent intestinal necrosis, perforation, and peritonitis. It is not GERD. In an infant, GERD presents with frequent regurgitation without excessive irritability. Bilious vomiting is a warning sign of structural cause of vomiting. It is not duodenal atresia. It's caused by failure of recanalization of the duodenal lumen. Duodenal atresia presents with vomiting and abdominal distension, as well as gaseous dilation of the stomach and duodenum on abdominal X-ray.
Can you read the intersusception?
Intussusception. Intussusception occurs when an intestinal lead point causes the small or large intestine to telescope on itself. It presents with episodic crampy abdominal pain, accompanied by crying, vomiting, and bloody mucoid stool.
Okay.
Okay.
In sigmoid volvulus, there is coffee bean shaped, isn't it? Like
Mm-hmm.
inverted U shaped or coffee bean shaped.
Mm-hmm.
And as the treatment, we will do endoscopic detorsion. Endoscopic detorsion. But in case of children, malrotation with midgut volvulus, there is dilated bowel with air fluid level. There is maybe pneumoperitoneum.
Peritoneum.
So midgut volvulus happens uh, in babies. Okay,
Mm-hmm.
next. A previously healthy 6 months old boy is admitted to the hospital because of 1 day history of fever, lethargy, and vomiting. His temperature is 102 degrees Fahrenheit. Pulse is 160 per minute. Respiration is 34 per minute. Examination shows nuchal rigidity. Examination shows nuchal rigidity and bulging anterofrontal. The remainder of the examination shows no abnormality, which of the lab studies show hemoglobin 12.2, leukocyte count 17,000, leukocyte count 17,300, platelet count 2,62,000. Sodium is very low, 121. Potassium is normal, chloride normal, bicarbonate is very low, glucose is 150. Which of the following is most likely explanation for these patients' sodium concentration?
Loss of chloride in the kidneys, secretion of ADH, ADH, insufficient intake of sodium chloride.
And anion gap is normal, isn't it?
Um, what is the anion gap again? Sodium minus chloride plus
Should we
bicarbonate.
go on that stage?
I don't think you. I mean, no. Okay, let's go.
1 day history of fever, lethargy, vomiting.
Okay, so he's been vomiting.
So is volume depletion.
No, because if he's been vomiting, then RAS will kick in and sodium will be high. Oh no. And between factitious hyponatremia and increased secretion of ADH.
Like
Big.
SIADH.
Yeah, because he has. I mean, the diagnosis for me is meningitis, or isn't it? Right or no?
Yes, okay. Uh,
Okay.
Meaning
So,
one of the cause of the infection, SIADH. Okay, you can,
so meningitis can cause SIADH,
yes,
and anemia. Okay.
can cause SIADH. Yes, I know the causes. CNS
Okay.
drugs, lungs and cancer. CNS drugs,
CNS,
lungs and cancers.
CNS, oh, I forgot what she said. CNS infection.
Drugs, lungs and the cancer.
The
Cancer is
meningitis.
small cell lung cancer. Though I have said lungs, lungs means the infection like pneumonia, like
Oh, okay.
pneumonitis, this kind of thing. And CNS is CNS infection. It can come with the meningitis or
Meningitis. Oh,
encephalitis. There are
oh,
some drugs like cyclophosphamide, as far I remember.
okay. Yeah. Then it's D, increased secretion of ADH. Fever, lethargy, vomiting, alternative snoca, rigidity, bulging anterior, yeah, meningitis. This patient hyponatremia is rarely caused by SIADH. Release of ADH by the posterior pituitary is typically simulated by increase in plasma osmolarity, but can also occur without stimulus in the setting of SIADH. SIADH can occur as an adverse effect of medication like cyclophosphamide, paraneoplastic process, or secondary to CNS disorder like a stroke, hemorrhage, infection, trauma, or tumor. In this patient, the cause of HID is likely result of meningitis. Treatment of hyponatremia involves treatment of any underlying disease and gradual sodium correction, typically with fluid restriction. Safe rate of sodium correction is generally no more than 6 to 12 per day. When hyponatremia is corrected too rapidly, extracellular sodium exerts osmotic pressure that leads to rapid efflux of water from neurons, which can lead to demyelination. Pons is particularly vulnerable to demyelinating injury, and rapid correction of hyponatremia can result in central pontine myelogenesis.
Demyelination.
Oh, Divine has a good thing for that. It's like from high to low. Oh,
Sorry,
no, like Divine has a mnemonic for that. It's like when you correct the
rapid
sodium,
correction.
yeah, of sodium, it's
Yeah.
like from low to high, the pons will die. from high to low. I forgot
Water
the
will
name.
come, cerebral edema.
Yeah, but he has from high to low, the brain will blow. Yeah, cerebral edema. Anyway, what was the other one? I was confused between.
Can you say it again?
He was saying from low to high,
From low to high, pawns will die.
ants
From
will die.
high, from high to low, the
The brain
brain
will,
will blow. Okay,
yeah. Anyway, yeah, it just came to my mind. Factitious hyponatremia due to
that's good.
hypo. Yeah, he's good, right? Because every time he, I was like, huh, that's funny, but it's actually it makes sense. Yeah. Factitious hyponatremia due to hyperglycemia can occur in patients with severe hyperglycemia. This patient glucose is only like 150, which will not be enough to cause hyponatremia on lab evaluation. Severe
Is there
hyperglycemia.
any way of finding SIADH apart from the cause in this question?
What do you mean?
Like how you find a conclusion that this is SIADH?
Oh, no, you the one that helped me. I
No,
was
no,
between.
I know the causes. The
Okay.
problem in me, like
Uh-huh.
I have information, but I can make it output. You got my point. But your thing is like I know it very well. Like I know plenty of things, but I can't. Uh, what can I say? If you don't express your knowledge in the battlefield, it is nothing but a waste of what can I say? It is nothing but a waste of weapon.
Mhm.
So, like I am looking for how you find the SIADH. Like what drags you to go for SIADH. Like
Mm,
in SIADH, like if we go through the
mhm,
uh, previous, like how evaluation
mhm,
of the hyponatremia, if we go
mhm,
through that box,
mhm,
on that box they actually say that if serum osmolarity is more than 290, but in
mhm,
here serum osmolarity is not given.
mhm, mhm, mhm.
So serum
Yeah,
osmolarity, if it is
yeah,
more,
you cannot use that box here.
yes.
Yeah.
So how you find the conclusion? Like
I
what?
For me, I came up with the two because I deleted all the other ones. Like I knew it wasn't excessive water intake,
Because
because
6 months baby is not
yeah, that doesn't
taking
make
water.
yeah, doesn't make sense. He's sick. He's not gonna be drinking water. I knew it wasn't increased loss of chloride because chloride is normal here. So if it's loss of chloride, chloride will be low in the serum. And I knew it wasn't
But
insufficient.
vomiting causes to low chloride, but in here chloride is normal.
It's normal, so it cannot be C. The answer cannot be C.
Okay.
And insufficient intake of sodium chloride. I do not know what that means, but it just didn't make sense. Because I guess sodium, I guess insufficient intake, okay, sodium will be low, but chloride will still, it just didn't make sense. And then intravascular volume depletion, it didn't make sense
Like
because, yeah,
in hyponatremia, we actually give salt tablet, but not for 6 month old baby. Okay, yes,
yeah,
that doesn't
yeah,
make
and they
sense.
haven't, yeah, they haven't said they're giving him anything. And then it's not intravascular volume depletion because yes, he's vomiting, so he probably has volume depletion, but his
Yes,
kidneys are fine, so RAS will kick up, and then sodium will be high, and then blood pressure will be high. They didn't give the blood pressure, but sodium will definitely be high, and potassium will be low. So it's not volume depletion. So I was between factitious hyponatremia and ADH. Factitious hyponatremia could be the answer, but the glucose was not too high. If
yes,
it would
glucose
be
was
like,
not that.
yeah, 500 or whatever, yeah, I guess, but the glucose is not so high. So that's what I was like, okay, I'm between that and ADH. But I couldn't remember if meningitis was. I know strokes and tumors can cause SIADH, but I didn't remember if meningitis was one of them. That's why I asked you. Yeah.
Yes, stroke like meningitis, trauma. This CNS disruption can cause SIADH, and the small cell lung cancer one of the important cause. And in drugs like Sorry, I said cyclophosphamide. It is not cyclophosphamide. It is carbamazepine,
No,
chlorpromazine.
it's cyclophosphamide is right here.
Oh,
Cyclophosphamide.
cyclophosphamide is also present.
Uh-huh, uh-huh.
Okay, that's good. Then cyclophosphamide, carbamazepine, chlorpropamide, and desmopressin. And lungs is pneumonia, TB, and okay, and ventilator use. These are the common causes
Yeah.
of SIADH.
So that's what kind of what I always, because I'm always like, okay, I don't have time to really think about, unless I already know the answer and I just look for the answer in the questions, in the like I already know the answer, so I just go to the answer choice that has the answer that I already know in my head. I cannot waste my time trying to think, okay, what's the diagnosis? So I just start eliminate. So at least I'm left with one or two.
Yes,
Most
yes,
luckily one, but usually it's two.
yes. But uh, I don't find a conclusion until unless I get the diagnosis.
Yeah, I know
That's
you
my
like
problem.
I know you, but it's like because
I,
I feel
I,
like
I try to exclude the information, but I failed. Sometimes I actually got the wrong answer. That's why I don't use that tactics. But I am
I
trying to.
yeah.
Your tactics is very good. Like
Yeah,
it is
because I
very
right now we have time, so you have time to think. But I feel like during the exam,
yes,
like you're gonna start thinking, okay, you yourself is gonna start thinking your mind, okay, I'm spending more than a minute. This is this. I'm spending more than a minute in this question. This and you yeah, your brain is gonna tell you you are already spending too much time on this question. So I'm like, okay, let me just at least if I don't know in my brain I feel like if I only have two answers, it's easy for me to choose than if I have like
yes,
five
that's
answers.
that's actually very good.
Sometimes it works, sometimes it doesn't.
Yes, most of the people actually go through excluding method. I know that.
Yeah. Yeah.
Okay, I, I am learning. Life is all about a learning process.
No, and I'm learning also from you because the whole thing with the images, it saves me times when you told me. I hate it. I'm always scared, like, oh my god, I'm gonna miss something if I just look at the
No,
image
no.
and the question. But
If you know the image very well,
yeah, yeah,
you will save at least
yes,
2 minutes. At
yes,
least 2 minutes.
because I've been
And
doing that
and
in
uh, in most of the blocks you will got
Mhm.
actually 3 to 4 images,
Yep,
maybe one ECG, and if
yeah,
you can deal with that, your 5 to 6 minute will save.
yeah,
You can utilize that time on biostat because
yeah,
the biostat one you cannot get the answer without
yeah,
reading.
yeah. So that thing, that trick helped me. Even if I'm still like, I'm always like, oh my God, I don't want to just look at the image, but I force myself to do it. And it usually, most of the time, it works. And I'm like, okay,
Yes,
and I save
images
time.
are good and it is rememberable.
Yes. Like you see the one with we keep getting the lime one.
Yes.
And I'm like, yeah. Okay.
Okay. Question 8. A 2-month-old boy is brought to the physician for a well child examination. Pregnancy was uncomplicated. He was born at term following forceps delivery for fetal heart rate deceleration. Apgar score was Apgar score were 4 and 8 in at 1 to 5 minutes respectively. 1 to 5 minutes respectively. He is at 50 percentile for length and 75 percentile for weight. He keeps his head turned to the right. He keeps his head turns to the right and cries when it moved toward the left. Examination. He keeps his head turned to the right and cries when it is moved toward the left. Okay, got it. Yes. Examination shows flattening of the half of right posterior part of the skull. A 1.5 centimeter mass is palpated in the left side of the neck. Which of the following is the most likely cause of this patient's finding?
Ready?
It is torticollis, isn't it?
Yeah, probably.
Okay.
So, a sternomastoid injury. This patient likely experienced injury of the sternomastoid or sternocleidomastoid or SCM muscle as a result of birth trauma leading to congenital torticollis. Torticollis refers to an abnormal contraction of the neck muscles that results in head tilting to one side. Congenital torticollis typically presents between 2 to 4 weeks of age with preferred head position, decreased cervical range of motion, and a mass on the SCM. Hypothesized causes include birth trauma, forceps delivery, or intrauterine malposition of the head, which may lead to SCM injury, and consequent fibrosis and contracture of the SCM. The fibrosis may present as a mass of the SCM on physical exam. Birth trauma or intrauterine head malposition may also lead to plagiocephaly, uh, flattening of the head. The diagnosis of congenital torticollis is clinical. Treatment requires physical therapy, interventions to stretch the sternocleidomastoid, which leads to resolution of torticollis in most infants. Next.
Okay. Oh, okay. Uh, what can I say?
Yeah.
You can give one NBME and uh you can, like, you have left four NBME, isn't it?
Mm-hmm.
The three NBME you can give before the exam,
Mm-hmm.
but you can give one NBME in this month or within the next month. So to find out uh, where is the condition now. You got my point, what I am talking about. Or
Mm-hmm.
you can go through free 120. Have you even appeared the free 120?
I've
Which,
seen, I've
okay.
done them. Now I don't know how people are able to figure
There
out
are
which.
like three free 120.
Okay,
Three,
then I
three or
probably do.
four.
I
In the
don't know how
in
people.
the Reddit I have seen.
I don't know how they're able to see which one is new, which one. Because when I go to the free 120
That one
thingy,
is the new.
I don't know how they're able to find which one is new, which one is not.
Like, do you have this higuru.com? I'm sending you the link.
Oh no.
There are plenty of things, like plenty of resources. I am not just talking you the here and there resources. I am just specific resources. Okay, I'm sending
Mm-hmm.
this one. Go to this link first.
Which one? Let me see.
Because why I am saying so, because this is the free 120. 120. Is it with answers?
Below explanation for every.
Just click in here. Okay, then
So
yes,
which one?
click here. They will not charge any money, so don't
I
worry.
know. Uh-huh.
Okay,
Um. So which one is it? What do you?
where is the thing?
Just
Step 2, test.
this one.
Yes,
Okay.
yes, this one. You can go through all blocks or you can go through single blocks. They will, if you just log it out, then your question answer will be disappeared. You got my
So
point.
how do you know that this is the most recent?
Maybe this is the reason, as far I know.
Okay.
May not be.
Okay. That's my thing because I've gotten here, but I don't know how people are able to know. Okay, this is the most recent. And you said this is
It,
only one of. One
This
of
is
them.
this is only one of them, but there are other two.
How do you find the other two?
I will give you the link, or I
Okay.
will just download them. I
Okay.
have, but my mm, wait, I'm looking for the older one. Okay, I have found. Okay, I'm sending you another thing. I'm sending you in here.
Where
Oh,
have you sent it?
wait, can't send here. Okay, I'm sending you in the Telegram.
Oh, you open Telegram. Telegram.
This is another old free 120. Have you found it?
Let me see. Yeah, it has to download. But okay, so that would be the old. So
Yes.
nice. But you said it's three in total.
There is another. I need to find that out also.
Okay.
In the Reddit, you haven't seen the post.
I've seen the post. I know I took two.
This
But
answer is at the last point. They actually just you scroll it down. This is the question. Go down. Yes, yes.
okay, so
You
this where
can
the questions
yes,
are.
you can mark it in here like what we are doing now. You got my point.
What are
Just
the answers?
answer is at the last.
Are the verses? Okay, got it.
Yes, you got it.
Okay, so
If
okay.
you don't understand anything, our there is another tool like Google AI or anything AI. You
Yeah,
can
yeah.
you can easily get the answer. You can easily get the explanation. So there are these things you should. Why I am saying you to give NBME, because if you give NBME, you will get a push. Like if you give NBME 11, we can solve it together, and as well as you can understand where you are and how much improvement you need to done before 1 to 2 months or before 3 months or before the exam. You got my point. I am there is free 120. These two things you have four NBME, as well as there are another resource like USA 1 and 2. If you USA 1 and 2, you may take before exam the USA 1 and 2.
Oh, I think I took one and two, but I had to pay if I have because I took it with the when I was
Yes,
taking the yeah, I had to
that
pay.
is that's the thing I'm talking. Like
Yeah.
if you want before exam, I think that you will buy it again and you will gonna solve that. So there are like six things. So you will not gonna time at the last month. That's the thing I am talking. You got my point. You have
Mm-hmm.
to start from now, like do it in this month, then do another NBME in the next month, and do 2 to 3 NBME in the next month, then you go for the exam. Okay. Uh, uh, what I have, I will just send you. Don't worry.
Okay.
Because these resources, if we do it like if we solve it together, we will get new idea.
Mm-hmm.
Okay. Uh, uh, in here, just I am saying you like don't log it out. Like if you get out from the exam,
Mm-hmm.
then your question answer will be removed and you have to give it again. You got my
Okay.
point.
Yeah.
So you will click step to all blocks, or if you want to do the single block, it's your wish. Then
Mm-hmm.
after doing that, you will solve at a stretch.
What is the passing score for this for the 120?
There is there is I think that there is no passing score. Like in here, people are talking about 70%, 80%. In the you will get the idea from the Reddit.
Okay.
If you go through some of the posts, you will get the idea.
Okay.
Okay.
Okay. Got it.
So my request is to you to give one NBME this month. Like,
Oh,
uh,
I don't think I can do MBA meet this. It's just I
because
don't think I can sit
if you
down for
don't do, like when you give the exam
or
and when you are solving the question, just two different things. That's
yes,
my
yes.
observation.
I can do I think I can do the 120 because it's just 120, right? It's just 120 questions. So I can do that, but I cannot do MBA because then
Uh,
when I do the MBS, I feel like I need to review it immediately.
yes, we will review. If you do
Yeah.
NBM 11, then we can review. Our pediatrics is question 6. Maybe there is another block is remaining.
We
Let
haven't
it.
even reviewed MBA 14. We still have an MBA.
Okay, well, I will. We will review NBM 14
We
in no
haven't
time.
even we haven't even and I feel like because the MBA like I like when I do an exam to review it immediately. So it for me it takes shorter time because when I leave a few days without reviewing and I have to come and review it, like I have to read every single question because I don't remember it. But when I do
Yeah,
it immediately, I remember
where
the question.
like uh, it has a both of it has both problem. Like
Mhm.
if you can't remember the concept, like you have given the NBME, if you don't remember
Mhm.
the concept, that means you are not master on that concept.
No, like I don't remember. I remember the concept. I don't remember the like. I have to reread. You know, some questions are long, so I have to reread the question entirely. I don't remember what was the question was about, and then I have to read the.
Okay.
So that's why I'm like, if I do the NBMs, I'll need to review it immediately because it's like so many questions. So that's why I'm like, I want to leave it at the last what 2 weeks, 1 month, 3 weeks because that's basically all I'm going to be doing. But you're right. If that's all I'm going to be doing for
No,
the last.
you will not gonna get much time on that time.
Mm,
But why is that? Because you are reading your resources now. In the
mhm,
last
mhm,
in the
mhm.
last month of your exam, you have to revise all the resources again. So you
Mm,
will not gonna get that plenty of time what you are thinking about.
yeah, yeah, but
Okay, no
but
problem.
I'll try the 120 though.
Yes,
The
if you
120.
do any 120,
Mm-hmm.
when you will gonna plan to do any 120, like the last one I have given, we can solve it together. Like we can explain, like we can see
The
the
last one you
explanation.
sent me, the last one, the one that you say is the last
PDF,
one.
yes, the
Uh-huh.
last one, the PDF.
But wait, no, you didn't send me a PDF. Oh, this one. Well, you say it's not the PDF. It's you say it's not the last one. It's the old one. This one, right? The old.
Yes, this one, the
Okay.
old one.
Okay.
The
Got it.
actual, the high guru, the that one, what I have sent you, the link. In there
The
you
link,
will
yeah.
get, yeah, in there you will get the, what can I say? You will get actual percentage. They will give a percentage.
Mm, yes.
It was just like the exam time.
Mm-hmm.
Okay,
Okay. Good. But that one, I won't be able to review it
which
because
one?
once the link you send me, like if I take it as an
You can review it also. How? This is the link
uh
in where you are giving exam. You will create another link where you
uh-huh.
will get the solve. You will scroll and you will get the answer in the below.
Uh-huh. Uh-huh.
If you just go back, then you will lost everything. That's why I am
Um,
emphasizing this.
okay. Okay, so when I finish taking it, I shouldn't close the window. I should leave it
Yes,
so I
you
can
should
so we can
not. You
review.
should not.
Okay.
Yes.
Okay. Okay,
If your
got it.
computer dies like now, the power is cutting.
Can
This
I
is
download it once I finish? Can I download? No, I can. It's not
no,
letting.
you
It
can't
won't.
download.
You cannot. Okay. Got it.
Okay,
Okay.
you can't. I as far you can go, you can click now. No problem. It you can do it 100 times. You go, you just click the link. I am seeing that if it is downloadable.
So I will do this. Show correct answers. Oh no. or show
No,
correct answer?
enable
No,
timers.
enable that. Do I put show correct answer? No.
No, no. Okay, start.
Okay, so I will do this.
Okay,
Okay, so it's only 40. Oh, it's four. It's three blocks. Okay, 40, 40, 40. Oh, and the end is the key.
yes.
Okay, 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 okay.
Okay, what you can do, like go to the question number one.
Mm-hmm.
You can click the photo one, the right one, the right. I have told you the camera
What
one
is
in the right. In the right, there is a camera.
which one in the phone?
Go
Oh,
up.
this one you had
Yes,
told me. Yeah.
yes. Go full page. Yes, you can do it like that. Just
Oh, sorry.
you click one question. Just click the PDF. You can go. You can, yes. Now it is download and go to the next question.
So I'll be doing that for every single question.
Yes, if you want to download it,
Hmm.
so you can do it like that.
Okay.
You got
Okay.
my point? Then you
Mm-hmm.
can, or you can answer, and then you can there. Y- you got my point. You
I can
first,
answer
you first,
everything.
you first click an answer. Then you can click the go full page, and then you
Mm-hmm.
can download. Then you
Okay.
can get like question answer sheet. You got my point?
Question answer. Yeah, but this is gonna take my time.
Yes, it will gonna take your time. That's the
Yeah.
thing I'm talking. But if you
Mm,
can do it,
mm.
okay.
Or I can just, it's fine. I can just leave it until the end and not to close my computer,
Yes,
and then
that's the
we just
good
review
idea.
it and there. I think I'm gonna do it, but with the click the right find the click the right answer or give you the right answer. So when it or not, you shouldn't do it like that. Give the right
No,
answer. No.
you do it like an exam. Then you can
Yeah,
review it. They
yeah,
will
yeah.
show you the answer.
Yeah.
Like how you do the NVMe.
Mm-hmm.
Okay.
Okay. Okay. Yeah, I may do that one just to see. But I wish I knew how much you need to score or whatever. I'll try to read it on Reddit.
You can go through in the Reddit. Some people get very good number in here, but some of them get very poor number. But this is predictable. This is good
The
because
good rate of
yes, everybody who is giving step 2, you will see that free 120. Everyone appear
yeah,
free
I've seen it.
120.
Yeah, I've seen it.
Okay, question 9.
Mhm.
You want to take a break? That
Sure.
as because we have talked a lot.
Yes.
But
Yes. Yes.
a previously healthy 7-year-old a previously healthy 7-year-old girl is admitted to the hospital. 7-year-old girl is admitted to the hospital because of 11-day history of fever, fatigue, and progressive non-productive cough. Fever, fatigue, and progressive non-productive. During the past 2 weeks, she has had decreased appetite. She has had decreased appetite, resulting in a 1.4 kg weight loss. The family lives on a farm of Missouri. The patient often plays in abundant chicken coop. Her direct contact to animals is limited to the pet dog and turtle. She has not traveled outside the state during the past 9 months, has never had has never been out of the USA. She appears alert. She is at 50 percentile height and weight. Her temperature is 37 degrees Celsius. Pulse is 110 per minute. Respiration is 34 per minute. Blood pressure is 96 by 57 millimeter of mercury. Mild wheezes uh, are heard bilaterally. The remainder of the examination shows no abnormality. Hemoglobin 12.3, leukocyte count 11,300. Segmented neutrophil is 48%. Lymphocyte is 46%. Monocyte is 4%. Platelet is 210,000. An X-ray chest, an X-ray and the CT scan show a blood culture obtained 4 days ago shows no growth. A PPT skin test performed 3 days ago shows no induration. A mumps control skin test shows 8 mm induration. A biopsy of the specimen mediastinal lymph node show necrotizing granuloma. Which of the following is the most likely diagnosis?
TB is not it's between lymphocytic leukemia, lymphocytic leukemia, and histoplasma capsulotomy, and Q fever, pet dog and turtle. Mm,
In this X-ray or CT scan, isn't it their bilateral hilar adenopathy?
probably yeah.
And another thing like millet-like opacity in the whole lung.
Millet like yeah. So you think it's TB? The TB is not showing no induration.
8 mm induration,
No,
mumps
that's
control.
months.
But mumps, okay, yes. You should know.
Maybe it's TB. Maybe it's not showing induration because of something.
Yes.
I don't know. Let me see. Why is it not ALL?
No hepatosplenomegaly, no
Okay.
lymphadenopathy, and
Uh,
look at the leukocyte count, not that high.
why? Why is it not histoplasmosis or Q
Mm,
fever?
A Q fever usually cattle filled, not the chicken one. Like in the sketchy, the
Mm-hmm.
cow is like what can I say? The cow
Mm-hmm.
is angry and like making the sand, and that's how the calf begins
Mm-hmm.
in the Q fever. But
Mm-hmm.
Q fever is not happened by pet dog or turtle. I don't think so. I don't know actually.
Okay.
And histoplasma, very
Histoplasma has the
bilateral hilar adenopathy.
lymphadenopathy. It does have mediastinal lymph
But
nodes.
histoplasma, okay, histoplasma can happen in the
Where is
Missouri or Mississippi, Ohio River Valley.
where is she? Oh, she's in Missouri.
Like histoplasma,
Mm.
isn't it the Mississippi, Ohio River Valley histohide
Yeah.
in the macrophage?
Yeah.
Okay, let's
Okay.
see.
Let's see.
Lots of things I have told.
What? It's
Plus,
histoplasma. Histoplasmosis is an endemic mycosis. I think we are used to the histoplasma with the caves and the
yes.
yeah. Endemic mycosis secondary to infection with Histoplasma capsulatum. Pulmonary histoplasmosis can present in acute, subacute, or chronic phases. characterized by fevers, malaise, myalgia, cough, hemoptysis with the associated development of small calcified nodules, and mediastinal or hilar lymphadenopathy. Mediastinal or hilar lymphadenopathy. Okay. Transmission occurs through inhalation of the organism's fungal spores. It is endemic to Mississippi, Ohio River valleys in the US as well as part of the Central and South America, Sub-Saharan Africa, and Southeast Asia. The virulence of Histoplasma capsulatum is dependent on its growth inside non-activated macrophages. Okay, which protected which protect the fungal cells from detection and elimination. Risk factors for histoplasmosis include exposure to bird or bat droppings, bird or bat, I guess the chicken. Diagnosis is typically made via the detection of histoplasma antigen in the serum and or urine. Histology will disclose oval yeast cells within macrophages encapsulating or necrotizing granulomas. And it's not, which one were we? ALL and AML, rheumatologic malignancy, ALL more commonly in children. The clinical presentation of both are similar as they are caused by relative burden of leukemic cells, including malaise, persistent fever, bleeding, bruising, bone pain, hepatosplenomegaly. Lymphadenopathy neither will demonstrate necrotizing granuloma on lymph node biopsy. It's not Q fever, vector-borne illness caused by infection with Coxiella bonnetti. Coxiella bonnetti is acquired through inhalation of the spores from cattle or sheep amniotic fluid, to which this patient did not have exposure. Q fever commonly presents as pneumonia and endocarditis. TB is caused by Mycobacterial tuberculosis, low-growing organism transmitted via respiratory droplets. It presents with primary latent or reactivation patterns. In primary disease, patients present with subacute fever, weight loss, night sweats, cough, malaise, PPD tuberculosis identifies exposure to TB and was negative in this case. Okay.
Okay. A 25-year-old woman, a 25-year-old woman, gravida 2 para 1, 20 weeks of gestation comes to the physician for a routine prenatal visit. She feels she feels well and her pregnancy has been uncomplicated. Examination shows uterus consistent with the size with the 20 weeks gestation. She reports that her first child has her first child had no bloody diarrhea as an infant when he was fed cow milk based formula. The diarrhea resolved when the formula was changed to hypoallergenic type. She states that she avoids dairy products because they upset her stomach. She asks how she can prevent food allergies in the next child. Which of the following is the most appropriate recommendation?
Ready?
Okay.
So it's exclusive breastfed for at least 6 months. Food allergies are component of the atopic triad. Are a component of atopic triad which consists of atopic dermatitis, asthma, and food or environmental allergy. Food allergy may be immune IgE mediated, urticaria, angioedema, anaphylaxis, or non-IgE mediated food protein, proctocolitis, enterocolitis. Exclusive breastfeeding for at least 6 months is hypothesized to decrease the rate of food allergy in infants. Dietary avoidance of allergenic food during pregnancy and lactation does not lead to decreased rate of food allergies in children. In actuality, introducing allergenic foods into the diet while lactating may lead to an increased likelihood of tolerance developing in the children and decreased rate of food allergy. It's not D&E. Use of hypoallergenic formula for at least 6 months or lactose-free formula for 9 months. It's not necessary nor shown to decrease food allergy development. In contrast, exclusive breastfeeding for at least 6 months is recommended. At 6 months, solid foods can begin to be introduced. Okay, next.
Okay. A 2-month-old boy is brought to the physician because of 2-week history of sweating fatigue during feedings. His mother has noticed that he seems to breathe first and has a pounding heart rate at rest. He was born at terms following an uncomplicated pregnancy and delivery. He is at 50 percentile for length, 5 he is at 50th percentile for length, 5th percentile for weight. Temperature is 37, pulse is 145 per minute, respiration is 70 per minute, blood pressure 90 by 40 millimeter of mercury. Examination show prominence of left precordium and a palpable parasternal lift. A blowing holosystolic murmur is heard best over the left lower sternal border. A chest X-ray shows cardiomegaly. A chest X-ray shows cardiomegaly and increased pulmonary vascular markings. Which of the following is the most likely explanation of these patient symptoms? This is too much.
Oh, jeez. Ready?
Yes,
Okay, so is left to right shunt. The left to right shunt from a large VSD is the most likely explanation for this patient cardiomegaly, increased pulmonary vascular markings, and failure to thrive. VSD are among the most common congenital heart malformations. The genetic cause of VSD is heterogeneous and includes known association with Down syndrome, the George Holt Oram syndrome. May also occur in isolation and via non-specific random mutation in individual point mutations that are de novo. VSD are characterized by allosystolic members in the left lower sternal border and may have an associated palpable thrill. VSDs result in the left to right shunt, which increases pulmonary blood flow. It leads to remodeling of the pulmonary vasculature and results in smooth muscle hypertrophy. In turn, concentric narrowing of the pulmonary arterioles occurs, which results in the development of pulmonary arterial hypertension. If severe and progressive enough, this can cause increased right ventricular pressure and associated myocardial hypertrophy, which subsequently results in reversal of the shunt Eisenmenger syndrome, representing with shortness of breath and cyanosis. Increased pulmonary blood flow results in increased blood return to the left atrium, which may cause left atrial enlargement. It is not seen. Increase increased peripheral vascular resistance, which also is also known as systemic. No, that's not what I was trying to think. Oh,
Okay.
peripheral and systemic. Okay, never mind. Next.
A 15-year-old girl is brought to the physician because of 3-day history of severe pain and swelling in her severe pain and swelling in her sternoclavicular joint. 10 days ago, the patient had a sore throat. 10 days ago, the patient had a sore throat. She has no history of serious illness, takes no medication. Temperature is 104 degrees Fahrenheit. Examination shows erythema, swelling, tenderness of the right sternoclavicular joint. Aspiration of the affected joint yields thick, yellow, purulent fluid. A gram stain shows numerous segmented neutrophils and gram-negative diplococci. Which of the following is the next step in the management? Mhm.
In between CT scan and leukocyte, indium level leukocyte. That doesn't make sense. Ready?
Yes.
So it is culture of the aspirate fluid. Never mind. This patient with monoarticular septic arthritis of the sternoclavicular joint from disseminated infection of Neisseria gonorrhea should undergo arthrocentesis with culture of the aspirate fluid. I thought they already did that. Hmm. Septic arthritis commonly occurs in children as a result of trauma to the joint, permitting the translocation of cutaneous organisms like Staph aureus. It may also occur in adolescents as a result of the dissemination of Neisseria. Neisseria gonorrhea is a STI, sexually transmitted bacterium that initially causes cervicitis, urethritis, pharyngitis, and may hematogenously disseminate to cause septic arthritis. Septic arthritis classically presents with painful red swollen joint along with systemic signs and symptoms of fever, chills, myalgia, arthralgia, and nausea. Monococcal arthritis may present with monoarticular or asymmetric polyarthritis disease, and may feature adjacent tenosynovitis and dermatitis. The most common sites of gonococcal infection are the knee, ankle, wrist, and elbow, though the sternoclavicular joint may also be affected. In all causes of septic arthritis, serum lab values typically show leukocytes, leukocytosis along with increased ESR and C-reactive protein. Diagnosis requires arthrocentesis, which typically demonstrates purulent aspirate fluid with an increased concentration of neutrophil predominant white blood cells. Gonococcal arthritis culture of the aspirate fluid may disclose gram-negative diplococci. Management requires antibiotic therapy with ceftriaxone and azithromycin. It's not DNA. CT scan of the sternoclavicular joint may assist in the visualization of a joint effusion. This is especially true in difficult to examine joints such as the hip. However, joint aspiration is the preferred method for definitely diagnosing septic arthritis. In indium label leukocyte a nuclear medicine procedure that adds a radioactive tag to white blood cells, assists in localizing signs of infection and inflammation, and is often used in patients with a fever of unknown origin. This patient possesses a clear source of infection. Wait, so here where it says examination, blah, 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 aspiration of the affected joint shows yellow thick purulent fluid. That's not the arthrocentesis.
Yes.
So why are we doing arthrocentesis again?
Arthosynthesis means aspiration of the joint fluid, and then we study under microscope, like we see in arthosynthesis, the cell count, like with for septic arthritis to happen in arthosynthesis, WBC count should be more than 50,000. That is the primary rule. And if it is less than 50,000, it may not be septic arthritis, it may be other arthritis. And in in after arthosynthesis, we can see the crystal. We can do crystal examination for looking for gout and pseudo gout, and we can see the glucose protein, like the microbiology. You got my
No,
point.
my question, yeah, but my question is they already did the actosynthesis. When it
Where
says aspiration of the affected joint
they
shows.
they only told you the aspiration of the joint fluid,
Uh-huh,
yellow, thick, purulent fluid. That
uh-huh,
means maybe it may be bacterial, because purulent fluid pass like fluid, thick fluid may be bacterial. And the gram stain show segmented neutrophil, and there is gram negative diplocus. So they already told you the organism that Neisseria, gonorrhea has gram negative diplocus, but they haven't done the culture. Like if you have done the aspirated fluid, now you need to do the culture for confirmation. There
the
are
culture.
plenty of tests in arthosynthesis.
What is the culture going to show?
Culture gonna show the specific organism like staph or gonococcus.
Okay. That,
They are looking for the specific organism, because only gram stain. They in Neisseria gonorrhea there may be another stain.
uh-huh.
Uh, the VCN stain,
Mm-hmm.
vancomycin, colistin, and you remember that thing.
Mm-hmm. Mm-hmm.
So we can do that stain, and for confirmation we can do culture and see on that what that media shows.
Okay.
Probably
Yeah. Okay. Next.
vancomycin, colistin, and nystatin, isn't it?
Mm-hmm.
What was the name of that media? Is it Thayer Martin?
Yeah, the VCN, right?
Yes, VCN is the detective Thayer Martin, isn't it? According to
Mm-hmm.
the sketchy.
Mm-hmm.
Okay, it is Thayer Martin media. The
Mm-hmm.
Thayer Martin media, they are we should give some antibiotics to
Mm-hmm.
prevent the growth of other organism, to specifically grow the niche area. Vancomycin, staph, colistin. Okay,
Okay.
okay. I need to read the question. Sorry. A 5,000 gram, sorry, big baby, a 5 kg male infant is born at term to a 35-year-old woman following an uncomplicated pregnancy and delivery. Following an uncomplicated pregnancy and delivery, initial examination show large. He is large for gestational age, macroglossia, visceralomegaly, omphalocele. Which of the following is the most? The infant is most likely associated findings.
Hmm. Is it hypoglycemia or polycythemia? I know you can
May
find
not
both. I
hypo.
mean, she doesn't. Uh-huh.
Oh, the big baby comes with the hypoglycemia.
Okay.
Do you have another idea?
I think I know they can have polycythemia too. Maybe I'm wrong. Okay, let's just do hypoglycemia. I feel like they do have it's hypoglycemia. Beckwith with Weidendamm syndrome is genetic disorder involving mutations of several genes located at the 11 chromosome. blockers that may result from a variety of mechanisms, including the effects of imprinting or, yeah. Beckwith-Whiteheim syndrome is characterized by cellular overgrowth and predisposition to the development of malignancy. Its presentation is heterogeneous but commonly includes an above average birth weight, macrosomia, macroglossia, visceromegaly, renal malformations on phallocyl, umbilical hernia. Yeah, children with Beck-Whittingham syndrome are at increased risk for developing a variety of malignancies such as webstoma or hepatoblastoma, although the underlying mechanism is poorly understood. As many as half of children with Whiting are affected by neonatal hyperinsulinemic hypoglycemia. The diagnosis is confirmed with cytogenetic testing. It's not polycythemia may occur in association with Beck-Whittingham syndrome, but is rare in comparison to hypoglycemia. Neonatal polycythemia commonly occurs in postterm infants and in infants with mothers affected by gestational. Oh, we thought that was gestational diabetes, but it's not. Okay, it's not congenital heart disease may occur either isolated or in association with other syndromes like Down. Congenital heart defects are not commonly associated with Beck-Whittingham syndrome. Okay.
Okay, Beckwith-Wiedemann syndrome, isn't it?
Mm-hmm.
Beckwith-Wiedemann looks like a BMW syndrome. Okay, BMW. So
Mm-hmm.
M is the clicking point. Macroglossia. There is macrosomia, macrosomia, and there is megaly. That means visceromegaly. So macrosomia, macroglossia, megaly, visceromegaly, and there is malformation like renal malformation. So 4M, the BMW 4M. Um, okay, and it is confirmed by cytogenetic study. I don't know how it can be remembered. Cytogenetic.
Oh, just like okay. It's a genetic. I think I'm just going to remember. It's like the diabetes mellitus baby, but with the diabetes mellitus baby doesn't have visceromegaly. This one has, and with renal
Yes,
issue.
malformation.
Yeah, and here the baby has of the renal issue. The diabetes mellitus doesn't usually have renal issues. So here it has hernias and renal issues,
Okay,
and it's a genetic disease. So you tested with the
gene.
genetic. Yeah. Okay. Next.
Yes. A 9-year-old girl is brought to the physician because of headache and dizziness for the past week. Headache and dizziness for the past week. She has a history of recurrent UTI. She has a history of recurrent UTI. At the age of 2 years, she received the diagnosis of the vesicoureteral reflux and was treated with prophylactic amoxicillin until the age of 6 years. She has been admitted to the hospital twice for the treatment of pyelonephritis. Development is appropriate for age and her immunization is up to date. Um, her height and weight is below fifth percentile, temperature is 37.2, pulse 980 per minute, respiration 16 per minute, blood pressure 160 over 100 millimeter mercury in all four extremity. Fundoscopy examination show narrowing of the retinal artery. Cardiopulmonary examination show no abnormal. Which of the following is the most appropriate next step in the diagnosis? There is hypertension, narrowing of the.
Ready?
Okay.
Okay. So it's measurement of urea and creatinine concentration. Measurement of serum urea and creatinine concentration is the most appropriate next step. This patient with chronic vesicoureteral reflux and history of recurrent pyelonephritis with new onset headache and dizziness. In the setting of hypertension, most likely has hypertensive urgency that has developed as a result of CKD. Chronic vesicoureteral reflux predisposes patient to development of recurrent pyelonephritis as urine from the bladder travels retrograde to the kidneys. Recurrent pyelonephritis can lead to scarring of the renal parenchyma and loss of nephron mass, which decreases the GFR and can lead to chronic kidney disease. Hypertension is a common complication of chronic renal disease and results primarily from impaired handling of sodium, leading to expansion of the intravascular volume and subsequent systolic hypertension. Over time, chronic vascular remodeling and increased systemic vascular resistance lead to an increase in diastolic BP. Assessment of the serum urea and creatinine concentration is an appropriate first step in assessing kidney function. Increases in both are suggestive of kidney injury. Further assessment of urinary protein excretion is also appropriate. Okay. Okay.
Why it is not CT scan?
Mm. CT scan of the head should be considered in patients with focal neurologic deficits of severe sudden onset headache to rule out hemorrhagic stroke or subarachnoid hemorrhage. This patient has had headache for 1 week and has no neurologic deficits reported. A CT scan will likely provide little additional diagnostic info, will not be the next step.
Okay. Next.
Mhm.
An 8-year-old boy is brought to the physician because of 4-day history of pallor. Uh, he has not as he has not had cough, rash, abdominal pain, vomiting, diarrhea. He is alert but pale. His temperature is normal, pulse 150 per minute, respiration 36, blood pressure 90, blood pressure low. Examination shows no abnormalities. Stool is maroon. Test for occult blood Test for occult blood is positive. His hemoglobin concentration is 8 milligram per deciliter. Which of the following is the most appropriate next step in the diagnosis?
Between X-ray and anoscopy. Mm, yes. Ready?
Okay.
Oh, Smeckle scan. Smeckle scan or Technetium 99 scan is the modality used to confirm Meckel diverticulum. This is a common congenital anomaly of the GI tract and it's characterized by a small diverticulum projecting from the terminal ileum that is approximately 2 inches in length and 2 feet proximal to the ileocecal valve. The diverticulum may contain ectopic gastric mucosa which secretes gastric acid leading to erosion of the intestinal mucosa and subsequent painless hematochezia and melena. Mm. In this case, the bleeding has caused iron deficiency anemia. Additionally, the diverticulum may act as a lead point for intussusception, obstruction of volvulus. In a Meckel scan, the pit is taken up by the metabolic active gastric cells and visualized in the right lower quadrant, corresponding with the ectopic gastric mucosa within the diverticulum. It's not X-ray of the abdomen is not sensitive for MECO. It's the first step in identifying small bowel obstruction. or ruling out GI perforation, but will not provide information about yeah. Upper GI series refers to a series of upper abdomen or X-ray taken after administration of oral control. This allows for visualization of proximal GIT to assess for for a variety of conditions such as duodenal atresia, malrotation, midgut volvulus, among others. And it's not anoscopy refers to direct visualization technique of the anus and distal rectum. Anoscopy is used to visualize bleeding hemorrhoids, which is another cause of bright red blood per rectum, but does not typically cause a decrease in hemoglobin. Okay, next.
A 7-year-old boy is brought to the emergency department 30 minutes after the onset of confusion and decreased awareness, headache, weakness, dyspnea. When his mother returned home from work, she found him sitting in front of the television with the space heater on and open packages of cookies and glass of milk nearby. The most appropriate treatment in administration of which of the following? So what he has done? Confusion, decreased awareness, headache, space heater.
Take like, mm, it's one of those poisons, but I don't remember the names.
What what has what is wrong?
It's probably one of those poisons, the carboxyhemoglobin or the
Oh,
methemoglobin or the
oh
what was
okay,
the other?
space heater. Carboxyhemoglobin, methylene blue, or carbon monoxide poisoning,
Um,
methemoglobinemia.
Methemoglobinemia was for methylene blue, but methemoglobinemia was it
No,
space heater and wasn't a space
what
heater?
was it?
No, I
Maybe
don't think
space heater can happen.
methemoglobinemia space heater. I thought methemog was like the okay, I don't know. Maybe not. Okay, ready?
Oh, okay. Yes.
So it's never mind. It's oxygen, it's carbon monoxide. I don't know why. Okay. Carbon monoxide poisoning occurs as a consequence of inhaling the gas, often because of its generation in an area of poor ventilation, garage with door shut or car running, and a space heater in a poorly ventilated room or malfunctioning basement furnace. Carbon monoxide (CO) is a byproduct of combustion. When inhaled, it rapidly closes the pulmonary capillary membrane and tightly binds to hemoglobin, inducing a conformational change in the molecule and preventing the binding of oxygen. CO has an affinity for hemoglobin that is hundreds times greater than oxygen, readily displacing the oxygen from the heme. CO also has affinity with the mitochondrial electron transport chain. Thus, in addition to hypoxemia caused by interference with oxygen carrying capacity, cells may not be able to make use of the oxygen they receive via aerobic metabolism. As a result, anaerobic metabolism dominates and lactic acidosis caused by hypoxia ensues. Symptoms of CO poisoning include headache, loss of consciousness, dizziness, vomiting, fatigue, severe cases, seizure, dysarrhythmia, coma, and death. Examination may show red skin. Treatment for CO poisoning begins with administration of 100% oxygen, regardless of pulse oximetry reading. And if neurologic symptoms or signs of endocrine dysfunction present, hyperbaric oxygen may be indicated. It is not ENF. The meccaprol is an antidote commonly used to treat arsenic and mercury poisoning, though it additionally chelates lead and gold in serum. I don't know why I use that here. Methylene blue is an antidote for methemoglobinemia. It serves to decrease iron in methemoglobinemia to from Fe3 to Fe2, restoring its ability to bind and transport oxygen. Methylglobinema may occur secondary to use of nitrates and anesthetics. Okay.
So nitrate and anesthetics for methemoglobinemia and garage combustion space heater for carbon monoxide.
There
And
was another one.
another
I
one,
forgot what was the other poison.
cyanide poisoning.
Cyanide. That was for what? For
Cyanide one also the garage, as far I
okay.
remember.
Okay.
Can you see it in the Google? Yes, yes, you can see here.
Combustion, fires, mining, and sodium nitroprusside. So fires, occupational exposure like mining, and the nitroprusside and nitroglycerin, those things. Mm, That's the cyanide poisoning, the CO poisoning, the smoke inhalation, the defective heating system. Yeah, the car one. Yeah. Oh wait, what's the antidote for that? Management, the contamination for cyanide, the contamination, and 100% oxygen. And empiric treatment with hydroxycobalamin and sodium thiosulfate. I don't know what is it. And then for CO poisoning, 100% oxygen. And then for methemoglobin, they don't have
100% oxygen and hyperbaric oxygen.
if they have those symptoms. They don't have methemoglobinemia. It's like the substances, the medication, dapsone, nitrates, anesthetic. And what's the treatment? There's no said the treatment. Hmm.
Methylene
Okay.
blue can be given.
Methylene blue, I think for methylene is methylene blue. Yeah.
So cyanide is plastic mining and sodium nitrochloride. And the
Yeah.
methemoglobinemia is like the drugs mainly. Nitrates,
Mm,
dapsone, local anesthetic, and carbon monoxide is smoke inhalation, like gas chamber
mhm.
gas. Okay. Defective heating, smoke inhalation. Okay. A previous a previously healthy 16-year-old boy, a previously healthy 16-year-old boy is brought to the physician because of 4-month history of progressive fatigue. 4-month history of progressive fatigue and nervousness. Intermittent blurred vision and declining school performance. He has 3 kg weight loss during the period despite an increased appetite. Her sister has hypothyroidism treated with her sister has hypothyroidism treated with levothyroxine. The patient's temperature is 37.5 degrees Celsius, pulse 120, respiration 18 per minute, blood pressure 110 by 80. Warm, flushed. Examination shows warm, flushed skin, soft hair. There is mild exophthalmos and lead lag. Fundoscopy examination mm, and visual field show no abnormality. Examination of the neck show enlarged thyroid gland and a bruit. There is fine tremor where the upper extremities are outstretched. Where which of the following is the most likely cause of this patient's finding? Isn't it Graves?
Probably, yeah.
Okay.
Tissue receptor. Okay. So it is T-cell receptor antibody. Graves' disease, autoimmune hyperthyroid condition caused by TSH autoantibodies that activate the TSH receptor. Hyperstimulation of the TSH receptor leads to overproduction of thyroid hormone and diffusely enlarged thyroid gland on physical exam, along with signs and symptoms of hyperthyroidism, including weight loss, insomnia, palpitation, heat intolerance, warm skin, tremor, diaphoresis, pretibial myxedema. TSH receptor stimulating antibodies also stimulate the orbital fibroblasts and lead to thyroid ophthalmopathy, which is characterized by expansion of the orbital fat and connective tissue with resultant exophthalmos, leak lag, and restrictive strabismus. Thyroid ophthalmopathy may lead to diplopia, corneal exposure, compressive optic neuropathy, and cosmetic appearance that is distressing to patients. Thyroid lab studies typically demonstrate primary hyperthyroidism um, with increased thyroxine and T3 and T4 and decreased TSH. Radioactive iodine uptake nuclear scintigraphy typically demonstrates diffuse abnormally increased uptake of the thyroid gland without the discrete node. The Graves' disease is treated with antithyroid drugs such as metimazole or PTU. Radioactive iodine ablation of the thyroid gland, thyroid ophthalmopathy typically responds well to topical lubrication, although severe cases may require IV steroids and stage surgical approach. Next.
Okay. A 2.8 kg newborn has a strong cry immediately after delivery. She was born at term following an uncomplicated pregnancy and a spontaneous vaginal delivery complicated by a few deceleration. Newborn was suctioned in at the perineum and placed in the warmer and resuscitation table. After 10 seconds of warming, the newborn's pulse is greater than 100. Respiration 20 per minute. Examination show peripheral cyanosis and a minimal movement of the upper and the lower extremity. Which of the following is the most appropriate next step? Ready?
Yes. Okay, so it is tactile stimulation and oxygen therapy. The initiation of breathing following delivery is crucial for newborn. A substantial portion of neonates require assistance with the initiation of breathing. Initial universal step after delivery include an assessment of the newborn heart and respiratory rates, muscle tone reflexes, color, immediate warming, drying, and tactile stimulation, all of which are helpful for stimulating spontaneous respiration. Neonates who fail to respond to gentle tactile stimulation should be um, immediately supported with more invasive support techniques, such as bag and mask ventilation or endotracheal intubation. Tactile stimulation and oxygen therapy are non-invasive and are therefore appropriate initial steps. Wait, I thought the baby minimal movement. Okay, it's not positive pressure ventilation via face mask and immediate intubation are both appropriate next step if the newborn remains apneic and does not respond to initial efforts of tactile stimulation. However, these methods are more invasive and are not appropriate first steps. Okay.
A 2-week-old newborn male, sorry, 2-week-old newborn female is brought to the physician because of bruising on her arms and the legs, bruising on her arms and the legs for 2 days. She was born at term following an uncomplicated delivery. The pregnancy was precepti- precipitous, but the newborn fed well soon after birth. Examination shows petechiae over the examination shows petechiae over the face and the trunk, scattered ecchymosis over the extremities, and erythematous fleshy irregular mass on the thigh. A bruit is heard over the hepatic area. Lab study shows hemoglobin 13, leukocyte count 5,000, platelet count 15,000. Which of the following is the most likely underlying cause of this patient's finding? Ruiz are
Mm, 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 mm,
fleshy irregular erythematous fleshy irregular mass. Bruit, low platelet.
neurofibroma, juvenile xanthoplasma. I've never, I don't know. Bruit of a hepatic lymphangioma. Oh no, I don't know that one. Okay, ready?
Okay,
It's hemangioma. Okay, so large vascular neoplasms or hemangioma, including tuft hemangioma and caposiform hemangioma and endothelioma, mm, are associated with consumptive coagulopathy characterized by severe thrombocytopenia and decrease in fibrinogen and other coagulation factors called Kabachak-Meri syndrome. These neoplasms present as red or purple subcutaneous tumor. The increased blood flow may cause the affected area to be warm and swollen or even cause a limb length discrepancy. Signs of other signs of other hemangioma such as a brood over the liver may also be present. The large convoluted vascular architecture causes platelet adhesion and trapping. This trapping leads to consumption of fibrinogen and ongoing fibrinolysis, causing a consumptive coagulopathy. Patients present, as in this case, with mucocutaneous bleeding, bruising, and petechia, which could not be explained by trauma. They also demonstrate thrombocytopenia. Treatment includes supportive measures to maintain homeostasis and treatment of the underlying vascular neoplasm. It's not a Cutaneous lymphoma has a variety of presentation. It is rare in children, particularly newborns. The most common type of cutaneous lymphoma is mycosis fungoides, an indolent cutaneous T-cell lymphoma. Mycosis fungoides present with scaly, wrinkled patches in sun exposed area, more often in adults than children. Patches in sun, and it's not, where was I? Lymphangioma are both lymphatic malformations. Cystic hygroma represent in association with Turner, whatever. However, neither of these are associated with Kasabach-Merit syndrome or the development of thrombocytopenia. It is not juvenile xanthogranuloma, it's an uncommon benign proliferation of histiocytes. It clinically appears as solitary orange-pink papule on the face, neck, or trunk of the child. It is not vascular neoplasm and does not cause, yeah, okay, okay.
okay. If it like if there is large hemangioma, which drug we can give?
Mm.
Like if it involves the eyelid, what drug we can use? Usually
Mm.
hemangioma is self-limiting, isn't it?
Mm-hmm.
I think that propanolol can be given.
Yeah, I
We
think.
have studied.
Yeah, I remember.
Okay. A previously healthy 6-year-old boy. Don't think that I am doing like I am asking hard question too.
No.
Okay, I am just recalling my information. Okay. A previously healthy 6-year-old boy is brought to the physician because of progressive hair loss over the past over the past 4 weeks. Examination shows a swollen and purulent area on the scalp. A photograph is shown. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in the management?
Improvement, progressive hair
Swollen,
loss.
purulent area.
That's not the fungal one, right? Probably not. It's not itchy. Hmm.
Slightly
No,
whitish lesion.
not the leash. It's the. I mean, also you think it's the dermatophytes one, but why is it swollen and purulent? I mean, he
Swollen and
doesn't.
purulent. Pus forming. Is it bacterial?
It looks like bacteria, but he doesn't have no fever and nothing, so it cannot really be bacteria. Maybe it's the dermatophytes. Oh, I cannot remove this. I think it's the
It
dermatophytes
is
one.
not surgical excision. It is no intervention. Is our option is in between B and C, isn't it?
I mean, it can be surgical excision because it's a purulent area. You never know. Um,
Swollen. Okay.
I'm actually
Is
between antifungal and surgical excision. Okay, let's check. So yeah, it was the tinea capitis. I never knew it was like swollen. I thought it was itchy with the anyway. Yeah, okay. So it's tinea capitis is you learn something every day. Tinea capitis is a fungal infection of the scalp common in children. The most common presentation is scaly patches with alopecia. I know that. Patches of alopecia may demonstrate black dots that present broken hairs. When a significant inflammatory response to the fungal infection occurs, a carrion develops. A carrion is a boggy and swollen lesion on examination. Tinea capitis is caused by dermatophytes, including Trichophyton rubrum. Yeah. First line treatment of tinea capitis is oral antifungal, usually griseofulvin or terbinafine. Close contacts of patients should be examined as the condition is contagious and can spread through fomites, such as shared palms, pillows, hat. It's not tinea. Which one was that? Tinea capitis is a fungal infection, not bacteria, and thus antibiotic therapy not necessary. Tinea capitis and keroid may become secondary colonized with skin flora such as Staph aureus, in which case antibacterial may be necessary, but this is atypical. Oral antibacterial therapy is appropriate for bacterial skin infection, such as cellulitis. Yeah. Surgical excision is unnecessary as the infection can be treated with oral antifungals. In children, dermatologic surgical excision is generally reserved for neoplastic processes. Okay, next.
next.
Mm-hmm.
A 3-year-old boy is brought to the emergency department. A 3-year-old boy is brought to the emergency department because of 1 day history of increasingly severe abdominal pain. His parents say that he injured his stomach when he ran the corner of the table 4 days ago. He cried immediately after the injury, but then seemed to feel better. Temperature is 37. Abdominal examination show 2 by 2 centimeter mass on the midline. Serum serum studies show increased amylase and lipase activity. Which of the following is the most appropriate next step in the diagnosis?
It should be CT scan, but he's a baby. So, I mean, he's a kid. So do we do X-ray? Because he's
In
a because I,
X-ray, can we find out the pancreatitis? Is
yeah,
it?
I know it's pancreatitis normally should be CT scan,
Yes.
but since he's a kid, do we do X-ray? Even if he's a kid, I guess we do CT scan. It doesn't. I don't know because I know in women you don't. Women and kids you don't do CT scan. You just do the ultrasound and I forgot what was the other one. Uh, mm,
If the woman is in the womb, then sorry, woman, not woman. The if the baby is in the embryo, then we should not do CT scan. In the normal
okay.
person also, I don't think so.
Okay. So I guess CT scan. Okay, let's check. Yep, CT scan. Children are more susceptible to intra-abdominal injuries after blunt abdominal trauma compared with adults because less developed abdominal muscles, less anterior abdominal flat, flexible ribs that transmit force to the intra-abdominal structures, anterior positioning of the liver and spleen. This patient presents after blunt abdominal trauma with a midline rise, raising concerns of duodenal hematoma. Okay, we thought it was pancreatitis, but it's not. Increased amylase and lipase concentrations have been shown to correlate with intra-abdominal injury after blunt trauma to the abdomen. Abdominal injury in children may be subtle. Clinical suspicion for intra-abdominal injuries should be raised when patients present with increasing should be when patients present with increasing abdominal pain or tenderness. Persistent emesis, increased amylase concentration, oh, wait. Abdominal pain, tenderness, persistent emesis, increased ambient bowel obstruction, and sepsis. The initial imaging of choice to evaluate for duodenal or pancreatic injury is CT scan of the abdomen, which may demonstrate duodenal hematoma. Duodenal perforation, pancreatic laceration, bleeding, and everything else. Duodenal hematomas can be complicated by proximal bowel obstruction as a result of the hematoma. Initial management may be non-operative for smaller injury. It may require exploratory laparotomy for severe persistent injury. X-ray of the abdomen may be used in the evaluation of severe bowel obstruction or perforation, but will not be helpful in assessing the presence of duodenal hematomas. Okay, next.
A full term 24 a full term 24-hour-old newborn has respiratory distress and seizure. Apgar scores were 8 and 9 in 1 and 5 minutes. X-ray chest shows hazy infiltrate. Leukocyte count is 12,500. Segmented 65% segmented neutrophil and 10% band. Examination of the CSF show full leukocyte 80 90 sorry full leukocyte per millimeter cube, 90% lymphocyte. Glucose concentration 75, protein is low. Which of the following is most likely diagnosis?
Protein is normal. Glucose concentration is high. Seizure. Mm, Cranial aspiration.
Is it
Cranial.
HIV?
Mm. What do you see HIV here? It's not on the answer choices. Please do.
Pneumocystis zeroviti?
Oh, that's what you're doing. Respiratory syncytial virus. It's definitely not a bacteria because of the
Yes, group B and pneumococcal rules out. It's not aspiration. So
and all
D and E is the only option.
yeah
Res-
should
respiratory
infiltrate.
syncytial virus (RSV).
I don't think it has bilateral infiltrate. Does it?
It
No, it doesn't.
usually don't. I
It
don't think
doesn't.
so.
Yeah. Okay. Let's check. We were wrong. Never mind. Neonatal sepsis. I mean, the CSF findings were like not. Neonatal sepsis is categorized as Jesus way, often on the basis of time from parturition, since the period of time in which symptoms begin may indicate which pathogen is likely involved, thereby guiding therapy. Early onset neonatal sepsis, like within like 3 days of birth, is marked by symptoms of lethargy, seizures, poor feeding with cry, hypotonia. It presents with tachycardia, tachypnea, occasionally fever, and often with examination that is non-focal. If examination findings are present, they may reflect the source of infection and may reflect complications of sepsis, such as NRDS. Early onset neonatal sepsis generally occurs as a result of pathogen acquired from the mom, either through hematogenous or transplacental spread or contact acquisition in the birth canal. The most common pathogen associated with early onset sepsis include Strep Acalache group B, E. coli, coagulase negative staph, diphtheria. Syndromes of serious bacterial infection include bacteremia, meningitis, and pneumonia. Late onset neonatal sepsis presenting 3 days or more after birth more commonly occurs from an environmental pathogen in addition to those acquired from the mom. Pneumonia is more common in early onset sepsis and presents with cough, tachypnea, tachycardia, hypoxia, increased work of breathing, and ronchi whatever. Workup for any suspected case of sepsis in a child younger than 30 days of age is broad and should include a CBC, urinalysis, blood culture, chest X-ray, lumbar puncture. At a minimum, since symptoms in this population are vague and non-specific, limiting the utility of the history and physical exam. X-ray in neonatal pneumonia disclose focal or diffuse airspace disease or major diffuse interstitial infiltrate suggestive of respiratory distress syndrome. Treatment include broad spectrum antibiotics to cover for common pathogens. It is not, where was that? D. Pneumocystis jirovecii pneumonia generally occurs in immunocompromised persons and was seen commonly in individuals with advanced HIV prior to the use of prophylactic antibiotics. Patients classically present with cough, fever, tachycardia, tachypnea, hypoxia. Okay, with bronchi on lung auscultation and prominent perihilar and multifocal infiltrates. Unchecked, it will be rare in neonates. RSV pneumonia is one of the most common causes of bronchiolitis and pneumonia in children younger than 2 years old. In the neonatal period, bacterial infection is more common. It's also more consistent with the neutrophil bands and diffuse infiltrates on X-ray. Mm,
Okay.
mhm. We have seen bronchiolitis comes with wheezing, and they say the PCP is not in neonates. Okay.
It
Next.
does not match with the
It
like
doesn't match with, I mean, it matched with the band, the leukocyte count, and it said neutrophil was high. But then the fact that they get the CSF fluid, I was like, okay, maybe they're trying to tell us that it's not. Because the
like
leukocyte count,
we have to think on that way. Like in the neonate, like 0 to 6 month, gel, group B, E. coli, and Listeria. These three can cause meningitis, and in here only group B is present. You got my point. Apart
yeah,
from that, I don't have any clue with the
yeah.
question and the answer.
If they hadn't put the cerebrospinal fluid, we would have gotten it right. Because
I
with
know
that,
that in case of baby, if the meningitis is suspected, They first do lumbar puncture instead of doing CT scan in the babies.
Okay, but it's like because they gave the results of the lumbar puncture, that's why we went for. If they weren't, if they just did, oh, we did lumbar puncture, that's it. They didn't give the results. We would have gotten it right. We would have known, okay, it's group B step probably.
Yeah,
But because they gave the results of the lumbar puncture with lymphocytes, and then glucose was fine, and then protein is like, okay, we didn't go to like bacteria, because lymphocyte wouldn't be high in bacteria. You know,
yes,
that's what happened. Okay.
that's the thing. Okay.
And here it's not even meningitis, it's like sepsis. Okay, it was okay. Okay.
And if they suspect about just sepsis, why they do lumbar puncture? Why they
Why
do
did you know
CSF?
that positive? Yeah, that's
That's
kind of
another mystery thing.
yeah. Yeah, that question was I don't think it was written the right way.
Okay, bad question. An 18-month-old boy has had cough, coryza, vomiting, diarrhea for 5 days, and pallor and lethargy for 1 day. Pallor and lethargy for 1 day. His mother states that his mother states that his urine output has decreased and the urine is now red. He responds poorly to stimuli. Poorly to stimuli. He has a grade 3 by 6 systolic murmur and with a gallop, diffuse abdominal tenderness. Diffuse abdominal tenderness. Lab studies show hematocrit 24%, platelet count 30,000. Hematocrit 24%, platelet count 30,000, serum sodium 138, chloride 118. Chloride is high, sodium is normal, potassium is very high 6.5, bicarbonate is low, creatinine is high 2.6, and BUN is high too. Which of the following is the most likely diagnosis? Okay,
Hmm. So it is oh HOS. Hemolytic uremic syndrome is typically associated with infection from the E. coli 0157H7 caused by the production of sugar toxin. Classically presents in children with bloody diarrhea accompanied by macroangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. Other pathologic precipitants include mm, the strep pneumo, salmonella, and shigella species infection. This patient presents following several days of respiratory and GI symptoms. Nobody said GI symptoms. Oh, vomiting and diarrhea. Never mind. Yeah. Suggesting a bacterial or viral trigger. The abrupt change of pallor and lethargy along with red urine and failing urine output suggests presence of blood anemia and renal failure. Um, Physical exam may show petechia, purpura, or ecchymosis, all of which are signs of thrombocytopenia. Lab evaluation demonstrates thrombocytopenia, increased creatinine and blood urea concentrations, and often multiple electrolyte derangement depending on the extent of volume depletion and acute renal failure. Treatment is supportive and may include plasma exchange. Many cases self-resolve. Generally, platelet transfusion is contraindicated because of the risk of worsening the degree of macroangiopathic hemolytic anemia, since platelet administration has been postulated to worsen the degree of thrombosis. If fever and neurologic symptoms are concomitantly present along with the anemia, thrombocytopenia, renal failure, TTP is diagnosed thrombotic thrombocytopenic purpura if there is fever and neurological symptoms. Good pasteur is a type 2 complement mediated cytotoxic hypersensitivity reaction that involves autoimmune deposition of IgG against the basement membrane in the lung and kidneys. Patients present with hemoptysis and nephritic syndrome, which may be rapidly progressive and cause renal failure or death, if not whatever. It's not PSGN, yeah? It's a nephritic syndrome presenting with gross or microscopic hematuria, peripheral or periorbital edema and hypertension in a child, typically 2 weeks after infection with uh, beta hemolytic group A strep. Lab evaluation may show low serum C3 and positive antistreptolysin. Okay, this one has had it for 5 days only.
Next,
Mhm.
a 5-year-old boy is brought a 5-year-old boy is brought to the physician for a well child examination. He is active and has been healthy except for an episode of otitis media 3 weeks ago, treated with amoxicillin. His parents immigrated from Vietnam. His diet consists of fruits and vegetables. He occasionally eats fish and chicken, but no red meat. Hemoglobin is 10. MCB is 64. Hemoglobin 10, MCB 64. Leukocyte count 6,000. 6,000. Platelet count 2,25,000. RDW is low. A blood smear is shown. Which of the following is the most likely explanation of this patient's anemia?
Right. The key is the red cell distribution. Is red cell distribution with
It is microcytic anemia, isn't it?
yeah. Thalassemia can also cause microcytic, right?
Yes.
But antibiotic-induced autoimmune, that I don't think it can cause microcytic. Between iron and thalassemia,
It
red
is
cell
not iron. In iron deficiency anemia, red cell distribution, RDW is high, isn't it?
red cell
And
dis-
in
okay.
the film, I think that I have found one target cell.
Target cell. Okay, so it's thalassemia.
I may be wrong. Okay.
You're probably right. What is it? Thalassemia. This asymptomatic child with mild anemia, microcytosis, and low RDW, red distribution with who is Asian heritage most likely has either alpha or beta thalassemia mania. I feel like we've seen this question previously. Thalassemia is characterized by the decreased synthesis of globin chains. Normal adult hemoglobin is known as hemoglobin A, 2 alpha, 2 beta, and is composed of two globin chains and two beta globin chains. There are four alpha globin alleles and two beta globin alleles. Mutations in one or two alpha globin alleles in, or one beta globin allele causes thalassemia minor. The thalassemia trait is common in Asia and commonly presents with mild microcytic anemia. Supportive features includes the presence of target cells on peripheral blood picture here, low RDW, which indicate that most erythrocytes are of the same size and with little variation. Mhm. And Persistence of microcytosis. Iron concentrations can be measured to rule out iron deficiency anemia. Other cell lines, including platelets and white blood cells, should be within normal limits. Hemoglobin electrophoresis can be used to distinguish between alpha and beta thalassemia. There is no treatment required for thalassemia minor. It's not iron deficiency is a common cause of anemia in menstruating women. Strict begins vegetarian and those with chronic GI bleeding and celiac disease. It commonly presents with microcytosis, although often with MCV that's higher than the thalassemia one, and increased RDW, indicating the release of premature erythrocytes from the bone marrow. Measurement of serum iron and ferritin, which will be low, are used to make the diagnosis. Okay, so the key was RDW here. Next.
Yes. A 17-year-old girl comes to the physician for a routine health maintenance examination prior to beginning college. She has had intermittent urinary frequency over the past 6 months without urgency or pain with urination. She feels otherwise well and has no serious illness. Menarche was at age 14 years. Mens occur every 3 to 4 months and last 3 to 8 days. Her last menstrual period was 3 weeks ago. She is not sexually active. She is 5 she is 165 centimeter, 5 feet 5 inch tall, weight 80 kg. BMI is 30 kg per meter square. Vital signs are within normal limit. Examination shows mild increase in the hair growth over the upper lip and upper extremity. There are hyperpigmented velvety hyperkeratotic plaque in the neck, axilla, and the groin. The remainder of the examination shows no abnormality. Urine analysis show no abnormality. Which of the following is the most likely diagnosis? There is acanthosis nigricans, isn't it?
Yeah, but yeah, so I would have gone with diabetes, but then all the signs of hyperandrogenism doesn't go with diabetes. So I was between ovarian
Ovarian neoplasm.
and Cushing syndrome. But ovarian neoplasm, yeah, I guess it could be that, but she's not losing weight.
Like how this Cushing can be matched. Like he has not has any history of taking steroid.
Maybe it's no. I just think Cushing, then you can be a lot of androgen release. So that will match with the pubic hair, whatever upper lip thingy. Then there can be a lot of
But acanthosis nigricans cannot come with the Cushing's.
acanthosis nigricans. Wouldn't that? Okay, I don't know. So
The
you think it's ovarian neoplasm?
feel like, but I don't know. Type 2 diabetes mellitus. It
It cannot
it
be
looks
that.
like piece, but her
It looks like PCOS.
yes, it looks like
It
PCOS.
looks like oh, I get what you say. You think they meant ovarian neoplasm? They mean PCOS.
Not
That's what.
really. No,
Not really.
no.
Okay. Mm. And then the urinary frequency thing. It just doesn't
Like
fit.
we need to think in PCOS people may have type 2 diabetes mellitus, isn't it?
Yes,
So we need to think on that way.
but there is nothing here that gives PCOS except uh,
Everything goes for PCOS.
that I'm saying the answer. There is nothing in the answer choices. Like the question, yes, gives PCOS, but the answer
PCOS
is
is associated with
diabetes.
diabetes.
Okay, okay. So you think it's diabetes? Okay, let's see. You're right. Diabetes. PCOS presents with irregular menses, infertility, hirsutism, and acne. often in patients with increased body weight. It requires two of the following diagnoses: an ovulation, PCOS or not, ultrasound, and signs of hyperandrogenism. It is also associated with signs of insulin resistance, such as acanthosis nigricans and increased blood glucose concentration, and is associated with an increased risk for developmental development of type 2 diabetes. Type 2 diabetes can be asymptomatic or present with polydipsia, polyuria, and acanthosis nigricans, as well as DKA or HHS. If severe, diagnosis require hemoglobin more than hemoglobin A1C more than 6.5 or fasting glucose concentration greater than 126. Initial management includes weight loss, lifestyle modification with the addition of oral antihyperglycemic. If yeah, Cushing syndrome presents with fatigue, hypertension, which it doesn't have, truncal obesity, hyperglycemia, fat redistribution, amenorrhea, and abdominal striae. It is less likely because of this patient menstrual irregularities, polyuria, and acanthosis nigricans. So, okay. And it's not ovarian or plasm, older postmenopausal female, abdominal distension, weight loss, uh, abnormal uterine bleeding, but you will see nasal mass and symptoms of diabetes not going to happen. Okay. I think they worded this question wrong. They should have said which of the instead of which of the following is more likely than I said. They should say like the diagnosis is related to which of the following.
Yes.
Yes, that would
Question
make
setup is like it is not the most likely diagnosis.
yes.
Okay.
Okay.
You want to do biostat or we
Oh
can
yeah,
continue?
yeah. It's the biostat.
Okay. Let's
We
do
haven't
some
done
biostat.
biostat in a while. I don't even remember which one we are. Clinical trial. I think we did confounding. Let me see. Selection bias, effect modification. I think they were in confounding. Is that the one that we're doing?
Okay.
I think last time we did a selection. Open with review.
Now confounding bias.
Yeah, we did selection. Yeah, we did selection and measurement bias.
Okay. A case control study is conducted. A case control study is conducted to assess the association between the alcohol consumption and the lung cancer. 100 patients with lung cancer, 100 patients with lung cancer and 100 patients are asked about their past alcohol consumption. Study, According to the study results, alcohol consumption is strongly associated with lung cancer. The researchers then divide the study into two groups, smoker and the non-smoker. Subsequent statistical analysis does not reveal any association with alcohol consumption and the lung cancer with either group. The scenario is described an example of which of the following. Okay.
Next.
A cohort study is conducted to assess the relationship between the oral contraceptives and the breast cancer. The study shows that in women with a family history of breast cancer, oral contraceptive use increased the risk of breast cancer with a relative risk 2.10 and a p-value 0.04 in women without a family history. In women without a family history, no effect is observed. R is 1.05, P is 0.40. The phenomenon described in an example, which of the following?
Hmm. I don't know. Selection bias. Latent period. Effect modification. I don't know.
Okay,
Okay.
next.
Next.
Case control studies conducted to evaluate the association between the alcohol consumption and the cancer of the oral cavity. The crude analysis shows a strong association between the exposure and the outcome. Odds ratio is 4.5, 95% confidence interval 3.4 to 5.6. Smoking is considered as potential confounder of the association. Which of the following properties smoking is essential in order to be considered as a confounder?
Confrontation of association from making is essential in order to be considered as a confirmed cancer of the oral cavity. And be prevalent in a population of interest related to alcohol consumption. It must be uh, observed only in alcohol consumers. Not be controlled for the analysis. Hmm? Must be observed only in alcohol consumers. Mm, okay, don't know. Next.
Yes. A case control study is conducted to assess the relationship. A case control study is conducted to assess the relationship between alcohol consumption and between alcohol consumption and breast cancer. First, the investigators interview patients with breast cancer, then they select neighbors of the patients with the same age and race to serve as the control. Such a study design helped to minimize the which of the following problems. Okay,
Okay.
okay. Okay, we need to understand the confounder and the effect modification. Okay, I'm reading the explanation. If I fall asleep, then just make me awake.
Okay.
Confound, okay. Confounding refers to the bias that results when the exposure disease relationship of the interest is with the effect of the extraneous factors confounders. In order to be a confounder, the extraneous factor must have some properties linking it with the exposure and the outcome of the interest. An example of confounding bias is given in question 1. Imagine that the results of the study in question 1 okay, the box according to the presented above the table, there is strong association between the alcohol consumption and the lung cancer. Odds ratio is 2.25. Once the investigators split the study subjects into smoker and the non-smoker, the results are obtained. It is 1.06. That means there is no association between the uh, alcohol consumption and lung cancer once smoking status is accounted for. The statistical method separation described is above described above is called stratified analysis. The statistical method of group separation described as stratified analysis. The association between the alcohol consumption and the lung cancer disappears after accounting for smoking status because smoking status is a confounder. To be a potential confounder, the risk factor must be related to the exposure and the outcome. Question 3. You can see the table above that smoking is more common among cases 60 versus 40 and alcohol consumes 83 versus 70. There is effect of alcohol consumption observed during the crude analysis, in fact the attributable to the confounding. There are several ways to limit the confounding in both the design and the analysis stages of a study. Design stage. Randomization is effective tool used in the clinical trial for control of both known and unknown confounding. Matching is another tool to limit confounding and is commonly employed in case control studies. Investigators identify potential confounding variables and select controls with variables that match those of the cases. For example, in question 4, age and race are identified as potential confounder. The control group is selected such a manner that both groups case control have similar distribution of the age and the race. Furthermore, case and controls are chosen from the neighborhood. Selecting neighbors as controls have another advantage. It matches the cases to controls by variables that are difficult to measure. Socioeconomic status restriction refers to limiting study inclusion by setting the certain criteria: age, severity of the disease. The downside of the restriction is that it limits generalizability, external validity of the study results. Analysis stage. During analysis, confounding can be dealt with thorough stratified analysis as described. Our more complicated statistical modeling methods are commonly used to isolate the effect of the exposure from the effect of the various confounding factors. Effect modification: when the effect of the exposure of interest on outcome is modified by another variable. In question 2, the effect of the oral contraceptive use on the incidence of the breast cancer is modified by the family history. Women with a positive family history have an increased risk. While the women without a positive family history do not have an increased risk. Other well-known examples of the effect modification include the effect of the estrogens on the risk of the venous thrombosis modified by smoking, and the risk of the lung cancer in people exposed to asbestos. Effect modification is not a bias. It is not due to flaws in either the design or analysis phases of the study. Effect modification is a natural phenomenon that should be described in the study design section but which cannot be corrected or eliminated. Okay,
Okay.
can you add something?
No, you got it right.
No,
What
I
is it?
don't got it. I don't get it. You can explain.
I feel like you just want me to, but you, which one did you not get?
The number four.
Number four, okay. Number four, number four. Uh, oh, it just says that when you do the matching, so you select the people, cases and control. You make sure they have the same age, they come from the same town, they are the same race, whatever. When you match like that, the cases and control, you are eliminating the confound effect
Okay.
when you. Mhm. Mm,
In
anything else?
matching, we need to eliminate the confounders.
Yes. Sometimes they say, okay, what can you do to eliminate the confound? Then you pick matching. Sometimes they say, okay, we
How
did all
can we
this.
differentiate between confounding and effect modification?
I think I don't know if it was Divine or my tutor that explained me. But when you add the confounder, in cases and control, when you add the confounder, then you find out that like the smoker thing, where was
Yes,
this one? This
there
one,
is no association.
there is no association. But when you add the effect modifier, you find out that the association is like stronger. So here it will be like the example of this one. Um, when you um, when you try to find the association between OCPs and breast cancer, it may be, yeah, there is some association. But when you add the family history as an effect modifier, then the association becomes like super high. So now OCPs definitely cause breast cancer because you added does it make sense? So
Yeah.
once one, when you add it, the relationship is gone. The other one, when you add it, the relationship is stronger. That's basically how I remember it.
Okay.
Mhm.
And the question three.
What was the question three? Oh, it says that the confounder must be related to both things. So you see here the smoking is related to lung cancer, but the smoking also is related to alcohol. Usually people that smoke drink a lot, or the people that drink a lot smoke a lot. So the confounder, which is the smoking, is related to both the alcohol and the lung cancer. So a confounder must be related to both the exposure and the disease. That's what they say for question
Okay. Okay.
three. Okay.
That's all for today.
Yep.
Okay.
We'll see you tomorrow.